Good morning, Mujahid.
Good morning. How are you?
Good. How are you?
Alhamdulillah, I'm good. How's everything going?
Yeah, it's going well. I'm trying to figure out this whole YouTube live thing. I already knew there was going to be problems. So,
Oh, yeah, you can expect that the first day.
yeah. Good morning, Melanie. Yeah, so like I had mentioned before, guys, there's going to be a lot of technical difficulties today because I'm trying to do the YouTube stream. But I do have a backup plan just in case it doesn't work. Um, because what Zoom will do is it will automatically record the lecture after it's done, which will enable me to post it on YouTube afterwards, anyways. So we've kind of figured out a way around that. Um, but in the meantime, I'll see if I can stream it live. It's just Zoom is making it a pain to try anything like that right now. Yeah, I think I'm just gonna have to mess around with that a little bit later. Because it's doing the live, but it's not showing my share screen, which really sucks. Would have been nice. Deb, how you doing? Penny, welcome back. Hope everyone's been well during this pandemic, soon to turn into an endemic like the chickenpox. Today, again, it's going to be more of an introduction, guys, and also to kind of gauge the material you want to see from this series. So we're still going to cover upper and lower body like we did last time. But again, my goal is to add more depth to what we did last time in terms of talking about function, talking about pathology, showing a little more realistic anatomical images. Sarah, welcome back. Hopefully everyone was able to download the PowerPoint slides. And we're just going to wait one more minute, guys, and then we'll get started. Yeah, I don't think this YouTube stream is working right now. Okay, I'm just going to end this stream. All right, just give me a moment. All right, so just a microphone and a camera check. Can everyone see me and hear me? And if so, just maybe throw a message on the chat or just say yes. Just want to make sure the audio and the video is working properly right now. Okay, perfect. And I have my chat window open, as well as my participants window open, but is that getting in the way of you guys, or can you guys just see the slides right now? Because if it's getting in the way, let me know and I can move them out of the way. I don't think it will, but if it is, just let me know. Just because I need to keep inviting people as they show up. Okay, perfect. Okay, so it's just me. It's just the meeting manager that will see it. Perfect. Yeah, so I'm using a bigger camera. I'm using a GoPro. So the reason why I switched to the GoPro instead of using the webcam like we did before is so when I need to get up and demonstrate things, we'll have a wider image as well as a better quality image. We also invested in a shotgun mic just to hopefully make sure the audio is a bit better than last time. Hopefully it is. I already see Sarah drawing all over the slide. That's awesome. But yeah, let's see how version number 2 of Human Anatomy Masterclass goes. Again, this one's going to be a lot of feedback. I'm going to be asking a lot of questions to get your feedback on what kind of stuff you want to see. Today will be very fundamental. It's going to be very similar to the very beginning when we first started, just to get you guys going through the fundamentals, because we need to understand the anatomical terminology, the planes, the types of tissues that are involved, and the types of joints to be able to understand everything else. So we have to go through the fundamentals first. And once we're through that, that's when the anatomy class is going to start looking a little more different. And it's just going to add to what the experience we had before. So without further ado, let's begin. So we're going to cover the major structures for each of the body regions. This is going to involve obviously the upper body, so the head, neck, shoulders, elbows, wrists, hands, as well as the torso, and then into the low back, hip, knees, ankles, and foot. And we're going to kind of go through the upper body first, and then the lower body is going to be right after. We're going to try to integrate a lot of physiological and biomechanical concepts to understand anatomical structure and function. So physiology meaning, at the cell level, as well as biomechanical meaning more like movement stuff. So how does our anatomy affect our movement and vice versa? We're going to be learning practical examples and how we can apply anatomy. And this is where I want to throw in more pathology because of my experience as a physiotherapist. So be kind of cool to do that. We're also gonna look through a number of mechanisms and abnormalities. So what happens when anatomy goes wrong, quote unquote. Um, yeah. So again, the lecture is going to be all done through the Zoom meetings. Um, the meeting link is listed as an announcement, so it's going to always be the same link. All you got to do is click it, and you are in access of the lectures. Again, we're going to be doing a 30-minute lecture per week. But what I actually added as well was an optional 30-minute discussion afterwards too. And that's just to go over any concepts or kind of like pick my brain about other things, but that's just an optional one, guys. So the 30-minute lecture will be the more structured one where we're going to be going over the material, and the 30 minutes following the lecture will be kind of discussion, kind of pick my brain about what you guys thought about the lecture, if you had any questions, and if you had any questions outside of anatomy but kind of related to things like physio, it'll be kind of that kind of format. Again, we're going to be doing PowerPoint slides for the lecture slides. I think that's the best way to go. I think everyone was okay with that last time. And then just regular attendance to maximize the learning experience is going to be really important, guys. It will be a little bit easier this time around because I will be posting the lectures immediately after. The YouTube live was supposed to do it instantaneously for me, but that didn't work today. I'm going to make sure it will work next time. But they will be posted every single week. So if you have to refer to it, or if you can't make a lecture, you're not going to miss out. Okay, that was an issue we had last time, and I felt like there was a little bit of fall off because of that. But we're going to make sure that doesn't happen anymore. Yeah, you can use Zoom through your laptop, your phone, whatever works best for you. Yeah, pretty straightforward. Again, for I guess a quick summary of who I am, because there may be some people that are new to this course that haven't taken it before. So I went to U of T for my bachelor's, went to Western for my master's in physio, and that's kind of where I got most of my education from. Currently working as a physiotherapist. And I guess when I was in my master's program, I enjoyed dissecting human cadavers a lot. And so that's kind of why I'm teaching anatomy. It's kind of a passion of mine, just learning the human body. There's nothing more complex than the human body, and I don't believe there ever will be anything more complex than the human body. People argue, technology, AI, this and that. There's nothing more complicated, and nor will there be. Other things about me, I've taught quite a bit before. I've taught this course before as well. I'm obsessed about basketball. So if you guys are a Raptors fan, I'm crying with you right now. It's really tough being a Raptors fan. I understand it's tough to be a hockey fan right now too, after what happened on Tuesday. So we'll not talk about that.
Yes, sir. I feel your pain.
Yes, I know. You know what? I have full faith in both of our sport leagues, so we'll see what happens. Big fan of mixed martial arts. I think mixed martial arts ties in really well with anatomy too, just because of how much the mixed martial arts stresses the body and tests it out. And above all, I love food as well, so I'm a big foodie. Odd facts about me: I had a shawarma restaurant, so I was making shawarmas before I was healing human bodies, I guess. Worked in accounting for a bit, hated it with all my passion, so I left that and taught calculus in private school. That's kind of where I started my joy of teaching. Yeah. Don't look at the dates. I forgot to change the dates. So scratch all those dates: April 7th to May 7th, 2020. Thank God 2020 is over. So don't worry about the dates yet. I'll be posting a more updated course overview, but it will follow the same order. Again, what we're going to be doing is going through introduction today, terminology, tissue, fascia, joints. It's going to follow the same structure as before, but again, we're adding to it. So We're adding to what we did last time for upper body osteology. We're adding to scapular muscles. We're going to add to the spinal cord. We're going to add to pretty much every single thing that we've covered last time to make it a more functional experience for you guys. Okay, so, and I still haven't figured out yet how to get rid of those scribbles. Maybe if someone knows how to do that, just let me know in the comments. And I don't know if you guys could see those yellow scribbles too, or if it's just me, but if anyone knows how to get rid of those, let me know. Otherwise, I'll just troubleshoot it later because I think we can still read whatever's on it for the most part. But yeah, today we're going to be identifying anatomical positions like we did last time. We're going to talk about the planes. I know some of the boring stuff, but it's going to be really important to go over. We're going to talk about the basic tissues of the body. We're also going to be talking about the different types of joints, as well as the degrees of motion. Okay. Any questions before we get started, guys? Alrighty. Oh, and one last thing, I'll be asking you guys questions like I was before. And that's just to kind of get your guys' take of if you're understanding the material, as well as, you know, seeing kind of the progression of the learning as well. Okay, so anatomical terminology. This is the anatomical position. So it's it guides us, it gives us a frame of reference as to kind of pinpoint where things are in the human body. We have the anterior view, which is the one to the left, and the posterior view, which is the one to the right. This is important and it never changes. Okay, so you have the palms facing forward. You'll see the foot completely on the floor, shoulders facing forward, obviously. And the legs are slightly apart. Okay, let's talk about the planes now. So we can kind of create 3 different planes in the human body, each having their own name. The frontal plane is the one that splits the front of the body from the back of the body. So if you look at this box over here, it's split in the front from the back. And this is how we kind of dissect the human body. So we dissect it in 3 different planes. And motions occur through these planes. So for example, with the frontal plane, if it splits the front from the back, you also have like this path of motion that moves from that plane. So things like lateral arm raises will move through that plane, as well as side leg lifts, jumping jacks. Those are all things that operate in the frontal plane. Okay. The next plane is the one that splits the top from the bottom. And that's called the transverse plane. And it's this one right here. And this is the plane that typically involves motions of rotation. So if you could think about things like trunk rotation, shoulder rotation, hip rotation, all these things. No worries, Sarah. Thanks for removing it, by the way. But all these rotations occur in the transverse plane. Okay. The sagittal plane is the last one, and that's the one that kind of splits the left side of the human body from the right side of the human body. And that's this box over here. And so most of the movements that we typically think of occur in the sagittal plane. So it could be anywhere from bicep curls to deadlifts to cat camels to squats, front raises. All these typically happen in the sagittal plane. And the issue with that is that, functionally speaking, most people, when they train at the gym, they only train in the sagittal plane, meaning they'll focus on their bicep curls or their front raises. And sometimes they'll do frontal planes. So sometimes they'll do the lateral raises. But one thing for sure that I notice, even functionally, very few people train in the transverse plane. So you'd have to be hard pressed to find someone that's going to grab a cable from one side and rotate it and strengthen the rotation. But the problem with that is that most of our functional movements for sports athletics actually come from rotation. If you think of a tennis smash or like a punch or even a kick, playing basketball, just moving the ball from one end to the other, these all involve rotational movements. So this is a place that most people don't address and should be addressed more often. And we're going to be talking more and more how we can incorporate transverse plane motions into exercise programs, for example. If the sagittal plane is the one that dominates all your workouts, this will lead to functional problems too. So you're strengthening a plane of motion without regarding the more functional plane of motion, which is the transverse plane. So this can lead to problems like injuries playing sports. Alrighty. Next one we're going to be talking about is kind of like the directional terminology. So first we'll talk about right and left. It's pretty straightforward. Right is the right hand, left is left hand. Anterior to posterior. So anterior is anything that's in front of the body, right? So a good example is the nose with respect to the ear, right? We would argue that the nose is what? Either anterior or posterior to your ear. Can we get an answer to that in the chat, please? So again, the question is the nose anterior or posterior to your ears? Okay, awesome. Everyone's on the same page. Okay, so that's anterior, posterior. It's a very simple one, but very important because again, everything is relative, right? For example, your nose may be anterior to your ears, but if you have if you're talking about it with respect to your chin, you might not be able to use the same terminology because it's kind of in the same position. So it's all relative, right? Okay, so we also have superior and inferior. So superior means above, inferior means below. Again, this is relative, right? So if I were to ask, what's more inferior, the hip or the knee? How would you answer that? So what is more inferior, the hip or the knee? Okay, perfect. Okay, so we know that the knee is inferior to the hip. But then if I ask what is more inferior, your tibial tuberosity or your patella, let's see if we can, I'm going to see if I can stress you guys out a little bit. So what's more inferior, your tibial tuberosity or your patella? Let's see if we can get some answers.
Tibial tuberosity.
Awesome. So we're getting a bunch of answers right there. Thanks to whoever said it on the mic. That's awesome. Yes. So if you remember from our knee lectures, the patella is the kneecap, and it continues on with the patellar ligament that attaches the patella inferiorly to the tibial tuberosity. All right. The next one is medial to lateral. Okay. So this one is also pretty straightforward. The medial-most thing we're going to have is anything right at the midline, right? So our sternum is probably the medial-most thing we have in our torso. Our belly button is the medial-most thing we have in our lower body, for example. And everything's relative, right? So your hand is lateral to your elbow. And why is that? Why is the hand lateral to the elbow? Can anyone answer that one? I'm asking a lot of questions today, but seeing if get some good. We've already been getting some really good answers, guys. So let's see if we can get some more. Thank you. Awesome, Melanie. So in the anatomical position, that was kind of a trick question, but someone got it right away. In the anatomical position, remember, The hands are actually a little further out from the body. So you can argue that the hand is more lateral to the elbow. And we also have that carrying angle of the elbow. So what that means is when your elbow is fully extended, there's going to be a little bit of an outward angle for your forearm compared to your humerus, correct? So that's why the hand would be more lateral to your elbow. Awesome. Okay, and then we have proximal and distal. So proximal means closer, distal means further away. So your knee is distal to your hip, but your ankle is distal to your knee, and your toes are distal to your ankle. Awesome. So we're going to go through the 4 basic tissue types right now. It's a lot of words in the slide, I know. I like to just go quickly over it because it's important to understand the histology and the physiology behind the human body as well. The epithelia is another way of saying the skin. It's pretty much a thin tissue layer that surrounds either the body or internal structures like blood vessels and the gut, right? So the epithelia around the human body, the one that you can see is skin, right? But things like blood vessels and guts, they also have epithelia, which are pretty much a number of cell layers that are kind of wrapping around structures to help support them. Okay. Then we have nervous tissue, and that just refers to nerves. The main components involve the brain, which is the control center. That's the executor of function. The spinal cord, which is the thing that connects everything, and the nerves that come out of it. So we have the peripheral nerves that come out, exit the spinal cord, and go on to muscles to cause contraction and receive feedback through sensation. Okay. And again, just to put away the myth, I think I talked about it last time because I hate this myth so much. The fact that we only use 10% of our brain is completely false. 10% of our brain are neurons, but the rest of them are very important support cells. So these support cells are necessary to provide like the right nutrient environment, the necessary support for the nerves. And without them, these nerves wouldn't survive a second. So we do use our whole entire brain. Let's get that out of the way. And then we have muscular tissue. These are contractile tissues, meaning they're kind of like an elastic band. You can stretch them and contract them. And they're either voluntarily controlled. So these are all the skeletal muscles of the human body. Those are the muscles that are attached to your skeleton. For example, your bicep contracts, causes elbow flexion. And we have the involuntary ones. And thank God they're involuntary. You wouldn't want to control your heart, nor would you want to control things like your gut. So those are the involuntary ones. We can voluntarily kind of shift how they move. So for example, if you're exerting yourself through exercise, you can indirectly cause your heart to beat faster. And if you, another one that's like a bit of voluntary, the only thing that's like a bit of both that we have in the human body are the contractile components that get the lungs to expand and contract, right? So the lung itself is not a muscle, but there are muscles around it, like the diaphragm and the intercostal muscles that cause the lungs to expand and contract. So that is done involuntarily most of the time. No one right now is thinking about, oh, I'm taking my next breath, I'm taking my next breath, I'm taking my next breath. Thank goodness you don't. But you can also, through deep breathing, as well as breath holds, you can voluntarily stop or accentuate the movement of those muscles. So that's the only exception to the rule. The breathing muscles, so to speak, are the ones that are both voluntary and involuntarily done directly. Okay. And last but not least, we have the connective tissues. So there's 4 categories. We have the proper loose connective tissue. That's the one that kind of binds everything together. So adipose is another way of saying fat tissue that's found in between the layers of skin and muscle. provides insulation. It provides a place where we can create our hormones from. Very, very important tissue. And then we have dense, proper connective tissue, which resists mechanical stress. So those are things that support our joints, support our muscles, like ligaments, tendons, and deep fascia. And we're going to get into a lot more detail of that later on. We have bone, and bone has a lot of function. It supports and protects our organs. So our rib cage, for example, protects our lungs and our heart. But more importantly, they are a site for attachment for muscles to which our body can act and move. They're also the most dynamic tissue we have, meaning if you were to break bone, it heals very, very well if you can put it back together in the right place. Even if not, if you don't get the proper unity between two broken ends, it will still heal, just in the wrong way. And when it heals, it actually heals stronger than it was before. That's another cool thing about bone. Last and not least, we got the cartilage, and that's the thing that provides the cushion and support between our joints. This is the one that's implicated in osteo and rheumatoid arthritis. That's one that's commonly lost when we have those problems. So they cover kind of the end of the long bones. So between your knees and between your hips are classic examples. These are pretty much the two main areas we get osteoarthritis. The reason why cartilage degenerates over time is through decreased joint space over time. So last year we talked about how joint space is really important between your, let's say, your shin bone and your thigh bone. You want a comfortable amount of space, and that space is filled with fluid, for example. But when the two joint surfaces come together and they get too close, a lot of degeneration can occur from constant shearing. Right. And so over time, that can lead to things like osteoarthritis and rheumatoid arthritis. Rheumatoid arthritis is more of a blood condition, but it's still related to degeneration of the cartilage as well. So those are kind of things to think about more clinically. And then we also have something called fibrocartilage, which is the cartilage that's in between the intervertebral discs of the human body. So think about the spinal column. We have the vertebral bodies, and in between them we have these little discs, and that kind of allows all the movements that can occur in the spinal cord. And we're going to go over everything anyways, but I just want to go through the 4 basic tissue types, get that out of the way. And it's already 9:30, so I want to see what else we have over here. I'll just get you guys to read the stuff on the fascia on your own time. That's pretty straightforward. If you have any questions about it, let me know. I do want to go over the joints. And if anyone has to leave again, just let me know, and the video will be posted on YouTube right after, I promise. So we also got the joints of the human body. This is where the movement does occur. And there are many types of joints. We have the ball and socket joint, we have the pivot joints, hinge joints, and they all kind of have their own important functions. So we have the fibrous joints. Those are the ones that are not necessarily there to allow movement, more so they're there to kind of allow two joints to kind of be connected like Lego to each other. So they're kind of involved with more dense regular tissue. They lack a joint cavity because they don't need it, they're not moving. And those are joints that you'd find in, let's say, your teeth, which is the gymphosis joint. You don't want those to move, obviously. You have a syndesmosis joint, so you have one in your distal tib-fib joint, and that's kind of like just to keep those two shin bones together, as well as the sutures of the human skull, right? So the sutures were there for development, but eventually they just became really dense connective tissue, and obviously we don't want those sutures to ever move. So those are joints, and they're there to not move. Those are the fibrous joints. Then we have the cartilaginous joints. They also lack a joint cavity, but they're a little bit more movable. There's a little bit more give to them. And this is functional, right? So you do want a little bit of movement through things like your symphysis joints, so the ones between the vertebra over here. You get a little bit, but when you add all the different levels together, it creates a lot of movement. The pubic symphysis over here, we have that joint. And that one you don't typically want to move except for childbirth, childbearing. That's when the body releases a hormone called relaxin. It gets to these joints, makes them a little bit more slack, and allows that birth canal to increase in size to allow things like childbirth. So that's the cartilaginous joints. They are a little bit more movable, but again, not trying to allow too much movement like the elbow or the hip, for example. And then we got the synovial joints. These are the joints that most people kind of consider joints. They're fluid filled with synovial fluid, and they're classified according to the degrees of movement that they allowed. So you have 1, 2, and 3 degrees of motion. Most of these fall under the category of 2 degrees of motion, but you'll have a couple of joints that allow 3 degrees of motion. And by degrees of motion, just think about your anatomical planes again, right? So 1 degree would be forward and back, another degree would be side to side, and another would be kind of like a rotation, okay? So the first one is non-axial. This will have 0 degrees of motion. Because it's not really hinging or anything. It's just allowing kind of like a shuffling between 2 bones. So we see that in our carpal bones. Those are 8 bones in the wrist that kind of connect to each other. They're not really allowing things to move, and thank goodness, but they do allow sliding and happen. So by their combination, by all them being connected to each other, we can kind of exhibit a lot of the motions of the wrist, but they're not per se singularly causing anything other than a gliding motion. So it's non-axial, meaning there's no kind of like hinging motion or any kind of degree of motion that's being exhibited, but they do allow motion when grouped together as 8 different carpal bones, okay? Okay, and then we have our hinge joints. So our hinge and our pivot joints, and these are uniaxial, meaning they move along a single axis. And the classic example is the elbow. But when you say the elbow, you got to be careful, right? Because we have a couple of joints in the elbow. We have the one between the humerus and the ulna, and that's more of a hinging joint. So that's the joint that causes elbow flexion and extension. But we also have the pivot joint, and that's between the radius and the ulna of the forearm. And so that still occurs at the elbow, and this is pronation and supination, right? And this is more of a pivot joint now because rotation is happening along 2 joint surfaces, and that's kind of at the bottom of this slide over here, versus the top where that's more of a hinge, but still happening at the elbow. So you can't say that the elbow itself is uniaxial because it's not. It has 2 different types of movements it could exhibit, but the separate joints in the elbow, the hinge joint of the humeral ulnar joint, that's just 1 degree of motion. That's the flexion extension. And the radial ulnar joint, the proximal portion of the radial ulnar joint, that's a pivot joint. That's only 1 degree of motion. Hence, it's also uniaxial. Okay. Any questions about that one? I know that's a little tricky right there. So the elbow itself can do 2 motions, but there are more than 1 joint in the elbow. Hence, each of these separate joints can only do 1 motion, but in grouped as the elbow, it's 2 motions. Hopefully that makes more sense. Okay. I want to go through just the rest of these joints, and then we'll kind of summarize and talk about the plan going forward. Okay, guys? So we got the biaxial motions, and these occur along joints that have 2 different axes. So these can involve the joints of the fingers as well as the joints of your thumb. So we know with the fingers, we can do flexion and extension, right, guys? What other motions can we do with the fingers apart from flexion and extension? I guess it's in the slide. Sorry, very easy answer to that one. But let's see if you guys can answer it anyways. So apart from flexion and extension, what can we do and what would that look like with the fingers? So what would that motion look like with the fingers apart from flexion and extension? And I'll give a hint to my basketball guys. Dikembe Mutombo was very known for this motion. Okay, maybe a
It can abduct and adduct.
yes. So yes. So yeah, we're getting some answers now. Awesome. Fingers together, fingers apart. You got it. So abduction, adduction, right? And the Dikembe Mutombo, that was the finger wag for all my basketball guys. So abduction, adduction, that occurs both at the thumb, both of the fingers, as well as the thumbs. The thumbs do that as well. Okay, but here's the difference, guys. With the fingers, they're condyloid joints. So think of them more of like a ball. It's not a ball per se, ball and socket. That's more of a shoulder joint, but it's kind of like a cup on top of a flat, curvy surface, right? So it allows 2 different degrees of motion. Whereas the thumb, it's more of a saddle joint. So it's not kind of a domey type shape. It's more of a saddle shape. So it still exhibits those 2 motions, but it doesn't look like the condyloid joint, which has more of a dome type shape. Okay, and then we got multiaxial movement as well. And these are my favorite joints. They're also the more complicated joints. So we got the shoulder joint. Which joint am I missing here though, guys? What else is a ball and socket joint? So we'll see if we get some answers for that. And right away, we're already getting answers. That's awesome. Okay, so yeah, it's the hip. The hip is also a ball and socket joint. So yeah, it's literally a ball and a socket. And because of that, you have 3 degrees of motion. So we have flexion, extension, we have adduction, abduction, and we have rotation. The great thing about the ball and socket joints is that they permit the most mobility, but the trade-off is they don't promote they don't promote as much stability, right? So with more mobility, you sacrifice stability. And this is why shoulder dislocations are the most common type of dislocations we have, because the shoulder, due to its mobility, it's kind of a little bit free. It doesn't have a lot of that bony kind of support the way, if we go to the previous slide, the way the elbow does. So if you look at the hip, the hinge joint, it's very stable. It's not going to move too much around it because it's kind of like stuck on. Whereas the ball and socket joint, because it's kind of loosey-goosey in the shoulder, it's at a higher risk of that dislocation. Now, the shoulder does still get its stability, but it gets it more from the stabilizers of the shoulder. Do you guys remember what the stabilizers of the shoulder were called? They have a specific name. And it's injured very frequently. Very, very frequently. Okay, we got one answer. Probably my favorite set of muscles, just because I have a short history of being a baseball pitcher. Yes. Okay. So Sarah's right. It's our rotator cuff, guys. It's the muscles that kind of originate from the front of the scapula as well as behind the scapula. We're going to get into way more detail later on, but they are muscles that attach to your humerus, most of them at the greater tuberosity, some at the lesser tuberosity, that kind of create dynamic stability. And we'll also talk about the importance of dynamic stability and why we should kind of work on it as human beings. For the hip, we also have stabilizers in the hip, and those are called our deep external rotators. So muscles like the obturator, the piriformis, the quadratus, we have a lot of hip stabilizers, and even at the level of the gluteus medius and minimus. Those are hip stabilizers too. So the body was designed in a way where, yeah, these joints don't have a lot of bony stability, but they'll still get the stability from the muscles. And your stability can improve the more you train these muscles, right? To get it ready for things like throwing, punches, in yoga, like holding stretches where you might be in a handstand, you need your rotator cuff to really fire. Holding a bridge, you still need your rotator cuff, right? So, so many different applications of using dynamic stability of the shoulder and the hip. Okay, cool. So that kind of covers the very basic fundamentals of human anatomy in terms of the joints, the structures, the planes, the motions. Now, I'll be. No, you know what? I wanted to get a little bit of feedback from you guys as to what you think. I'm gonna kind of like talk to you, and you let me know what you think about certain things. In terms of lectures going forward, I still want to kind of follow the format of last time where we had, we went to osteology, we went to the neck, shoulders, kind of went down the human body, and then we did the lower extremities. But to add more depth, I wanted to talk more about function. So what are your guys' thoughts about talking about pathologies? Like things that I kind of deal with a lot are like neck strains, whiplash disorders, rotator cuff strains, disc herniations, dislocation, stuff like that. Do you guys kind of want to go into more pathology as well as function? So kind of like training, exercises, therapeutic and corrective exercises, posture control. Those are some of the things I want to add to it. What are you guys' thoughts about that? And would you guys want to see things like X-ray images, MRI images, and I could kind of explain what we're seeing, kind of to give you more of a lens as to what I'm talking about. So I'm going to leave it to you to kind of leave some comments. To be honest, I just got to quickly use the washroom. I'll be right back. But I want to get some comments about what you guys think about that. Okay, I'll be right back in 2 seconds. Okay, perfect. So we're getting a bit of feedback here. Everyone's willing to dive into more function-based stuff, injuries. Great, great, great. Okay. Here's my next suggestion, guys. If you guys have any of your own injuries, what you can do is message me on Facebook, and maybe we can kind of add that to the lecture topics as well, because I think I want to kind of be of help to you as well, so you can kind of get something that could help you on your end as well. So if there are any kind of topics you guys do want to work with that have, more meaning to you in terms of injury or things you dealt with, or you might know someone that's dealing with something, I think it might be something that might offer a little more value to as well. So I do want to hear feedback. Even if you want to mention in a group, or if you want to just direct message me, either one works. But I think if we can do that, and that way you guys can kind of extract a little more value out of this, as well as pick my brain about what you might be dealing with as well. So yeah, let's get you guys to kind of give feedback about that as well, and I'll throw it into the lectures when it's time. So for example, if let's say one of you guys have dealt with a knee injury recently and want to kind of talk more about meniscal injuries, or ACL tears are very common, obviously. We can kind of dive into that a little bit more, and we could talk about things that you can use to rehab that. We can do that too, obviously. So let's make this more open. Let's make this something where it adds a little more value to you guys. And yeah, I think that's pretty cool. So and then we'll kind of throw it into where we're talking about it. So for knee lectures, if you've dealt with something, we're going to talk about it in a knee lecture. So again, ACL, we'll talk about a knee lecture. If it's more of a whiplash injury, you had kind of a car accident and you're still dealing with a lot of strain, we'll talk about it in the cervical spine lectures. That's kind of what I'm thinking of as well. But yeah, I'll leave the door open for you guys to kind of ask your questions if you have anything to ask. Otherwise, that's it for today. We're going to meet again Thursday next week. Again, I'll make sure that it's going to be all lecture for the first 30 minutes, and then I'll leave the second 30 minutes for questions afterwards. So if you have any functional questions at all, if you have any rehab type questions, just let me know and we can kind of talk through it over Zoom as well. Otherwise, thank you all so much for joining in today. I'm really, really excited to teach this course again. And yeah, we'll meet again on Thursday if we don't speak right now. No problem, Sarah, no problem. Thank you for showing up, Melanie. Thanks, Deb. We'll talk soon, guys. Judd, it's always a pleasure. All right, perfect. I will head out. Take care, Penny.